So today's speaker is Dr. Sonia Hernández-Díaz, who is a professor of epidemiology at the Harvard School of Public Health. So she serves there as the director of pharmacoepidemiology and the real world evidence program. Her research focuses on examining drug safety during pregnancy using primary and secondary observational data. She also has experience with case control surveillance studies, pregnancy registries, and pregnancy cohorts nested within healthcare utilization data. Additionally, her research concerns the application of innovative methodologic concepts to increase the efficiency and validity of observational studies. And in some of her recent projects, her team has emulated hypothetical target trials to evaluate medicines and vaccines in pregnancy. So without any further ado, I'll turn things over to Dr. Hernández-Díaz, who's going to be talking about emulation of target trials on vaccines during pregnancy. So welcome, Sonia.
Thank you, Dr. Beaton. Thank you for having me in the first seminar of the year. Very honored. And so I'm going to talk about this emulation of target trials on vaccinations during pregnancy. And I think vaccinations, because they are acute and transient and they can happen during pregnancy, are a little different from when we evaluate medications that often are used before pregnancy, and there are other implications about them. So, but what we learn about this example, I think, can be extrapolated to other type of exposure pharmaceuticals during pregnancy. So first, some disclosures. I have done a little consulting, including for Moderna for unrelated methods topics, and I'm not going to present results that I think can get me into any appearance of conflict, but just for full disclosure. So I'm going to briefly introduce the example of vaccine. Specifically, we are going to use COVID vaccine as an example and briefly introduce what do we mean by target trial, and then to give an example of target trial emulation to study the vaccine effectiveness and then vaccine safety. And I'm going to go deeper into two methodological things for those of you that are more interested in the methods aspects. And then we'll have conclusions and time for discussion. So yeah, please hold your questions if you can until the end, and we'll have enough time, I think. So the COVID-19 vaccine in pregnancy, as you know, some years ago, was used in pregnancy, in pregnant women. And by the way, I like the word women, but because I've worked on women's health for a long time, but I do mean human females of any gender identity. And because the vaccines were going to be used, we needed some causal knowledge about their effectiveness and safety in pregnancy in particular. And there were those large phase 3 clinical trials conducted to evaluate the safety and efficacy of COVID-19 vaccines, but they did not include pregnancies, even when there were some pregnancies. And we can have another seminar to whether that protection is a good idea or not. It's good intention, but at the end, because of that, after approval, there is little information. And that was behind the inconsistent initial vaccination guidelines regarding from contraindication to allowing to recommending vaccinations in pregnancy. And the lack of information on their safety was one of the main reasons for vaccine hesitancy in pregnancy initially. And when we don't have information from randomized trials, which are our preferred choice for causal inference, then the decisions are often informed by observational data. And in pregnancy, observational studies are often the main source because pregnant women are typically excluded from pre-approval randomized trials. So it's a good field if you want to do observational research. So now, what is a target trial? Causal inference from that observational data can be conceptualized as an attempt to emulate a hypothetical but realistic pragmatic randomized trial. And that's what we are referring to with the target trial. And it is just the randomized trial that you would like to conduct to answer your specific question if you had no limitations of funding, ethical reasons, or logistic issues. What is the ideal trial you would like to conduct to answer your question? So the target trial is not a magic thing that will get rid of all our problems in observational data. It is just a plan, a checklist that makes each aspect of our research very, very explicit, all the way from the causal question of interest and the estimate that we want to estimate to the analysis. So the first step is always, what is your question, and be very explicit about it. Then in this framework, you will design the hypothetical target trial, like as if you were doing a protocol for a real randomized trial. And then you try to emulate that protocol, a section of the protocol by section, using observational data. And by being very explicit, you can identify the things that you cannot emulate or the assumptions that you need. And then you apply the causal inference analysis. And we often focus on the fancy analysis, but that's only at the end of doing the other three steps correctly. So by designing that target trial, it can help us identify and sometimes avoid unnecessary biases, including some types of confounding, introducing immortal time bias or prevalent user bias. And the table for all these target trial emulation contain the protocol components from eligibility criteria, defining your treatment strategies, how do you assign the treatment, follow-up, outcomes, causal contrast of interest and analysis. You do it for the real target trial, hypothetical one, and then you do the same thing for the emulation. It's true that sometimes because of the data that we have, not all hypothetical trials are possible. So there is a little bit of back and forth of like, this is what I would like to do, but that I cannot emulate in the data. So you have to compromise. That doesn't mean that you go to the data and look at the results, but just knowing what you have in the data, which kind of information, there is a little bit of back and forth. Sometimes there are real trials that we can straight emulate, trials that have been published or protocols that have been published, and we can replicate or simulate those trials. But if those existing or trials to be have characteristics that cannot be emulated in the real world data, for example, they have biologic measures or they use placebo or they use blinding that we cannot emulate in the data, sometimes they are like an in-between step of this is the real trial, this is the target trial, a hypothetical that we can emulate. And there we can make modifications of that existing trial. For example, the real trial had adjudication of outcomes, but we cannot do that in our real world data. Okay, then the trial that we are going to emulate actually will have this pragmatic evaluation of the outcomes. The point is that at the end, when we emulate the target trial, the only difference between the target trial and the emulation is the lack of randomization. That's the ideal, that's where we are going with it. So in each part of the table, we have to pay attention to the things that we will do in the hypothetical randomized trial. So eligibility criteria, we need to be explicit about the population inclusion criteria, the same way we would do in a real trial. Treatment strategies in the real trials, we have very explicit initiation, duration, frequency. The thing is that with observational data, we know that we cannot emulate blinding, we cannot emulate placebo. So we cannot emulate those things. Don't even try to go there. The randomized assignment, right, that we do not have in observational data, and that's where confounding comes in, and all the methods that you know about confounding, including matching, stratification, IPW, you name it. So that's where you have to specify it in your protocol. How are you going to deal with the potential confounding or lack of comparability or exchangeability? Then we have the start and then follow-up. In pregnancy, we usually follow until the end of pregnancy or during childhood, and the outcome of interest that can be the same as in the target trial. And then you can define you want to do intention to treat or per protocol. You can try to emulate that as well. So going to the target trial emulation, first an example about effectiveness of vaccines. And for effectiveness, like large numbers are required for vaccines. So it will not be realistic to redo those large trials specifically in pregnancy. And because of this relatively healthy population, it will be not feasible. So back in the days, Israel started very quickly vaccinating everybody with the Pfizer vaccine, and they vaccinated pregnant women, and they had done these target trial emulations for non-pregnant populations. So we contacted them, and in collaboration, we look at a target trial emulating the randomized trials, but requiring pregnancy. So we included pregnant women between December and June, December 2020 and June 2021, at the right age, that were members of one of the healthcare systems that they have, the CLALID. They had almost real-time data. They have the ID, so they were in a very privileged situation to have really rapid generation of this information. And back then, we were able to require that the population had not had vaccination or infection before. Now, of course, it will not be possible. Then we define the vaccination schedule as was recommended back then. So 1 dose and then followed by a second dose 20 days later. And to emulate the randomization, we match every vaccinated by age and neighborhood demographic characteristics and clinical characteristics, including the same trimester of pregnancy and some risk factors for COVID-19 that were known back then. And then we follow them to emulate the follow-up in randomized trials, even when we like, of course, to follow everybody from time zero. We consider the 14 to 20 days after first dose and 7 to 56 days after the second dose, because those were the expected effectiveness period that vaccine trials had done. And we look at infection, hospitalization, and death, and consider a per protocol effect. So we knew who had been vaccinated, and use Kaplan-Meier curves to represent the cumulative incidence. So that's kind of like a summary of the protocol. That these are the results. To the left, you have the results for the cumulative incidence of SARS-CoV-2 infection, and to the right, same thing, but for hospitalization. In red, you have the cumulative incidence for unvaccinated, and in purple, blue, the cumulative incidence for vaccinated from the first dose times 0. Then around 20 days later, there was the second dose. And then for the in between the lines, the period that is considered the protective period with vaccine. So as you can see, similar to the effectiveness estimated in the general population, vaccine effectiveness was then 97% for symptomatic infection, 89% for COVID-related hospitalization during the 7 to 56 days after the second dose. So reassuring results. Moving on to safety. And with safety in pregnancy, sometimes we mean pharmacovigilance, like outside pregnancy, so vaccines reactions, local or systemic reactions. And we can assume that that was like relatively similar to non-pregnant populations with migraine and local pain, particularly after the second dose. But in pregnancy, when we say safety, we often focus on pregnancy-specific outcomes that are related to the fact that the mother is going through gestation, very special period with some changes happening, and also there is a fetus developing. So there are, for pregnancy studies, specific, we can call adverse events of special interest that can include pregnancy losses, spontaneous abortions, stillbirths, major congenital malformations, obstetric outcomes like preeclampsia, preterm delivery, and neonatal outcomes like small for gestational age or neonatal intensive care unit hospitalization, for example. And some studies even follow infants through childhood to assess hospitalization, neurodevelopmental outcomes, infections, etc. So a range of outcomes. And a challenge for pregnancy is that in addition to calendar time, and in addition to time from the vaccination or treatment, we have this crossing scale of gestation. It's an additional scale that we have to consider in our research. And to make things harder, the etiologically relevant windows for each of those outcomes that I mentioned changes. So first trimester for congenital malformations and miscarriages, maybe late in pregnancy for preterm. And the risk of some of these outcomes, like spontaneous abortion or delivery, also changes over time, almost like by week. So, for example, if we look at the distribution of pregnancy losses by pregnancy week, and by way we consider miscarriage pregnancy losses between 20 to 24 weeks, and then we call them stillbirths, right? So the clinical miscarriage risks by gestational week, meaning the clinical meaning that we can identify that there was a miscarriage, increases, peaks around weeks 10, 11, and then goes down. If we were to have information on subclinical losses, then there would be more losses in the first weeks after the last menstrual period. Conception is around 2 weeks after the last menstrual period. So the cumulative risk of miscarriage in the first 20 weeks of pregnancy is around 12-15%. So information that I'm going to use in the next slide. So yes, for those of you that might not be into OBGYN, that's the expected cumulative risk of miscarriage. So let's review some challenges for each phase of pregnancy, because we might want to do studies about vaccination preconception. And if so, then we have to think about fertility. Then we have to think about the challenge of how conception can compete with future outcomes. Or we can focus on vaccinations early in pregnancy, like I'm calling it phase 1. There is totally arbitrary. And then the challenges that we are going to confront there will have to do with dealing with the survivor cohort until the time of vaccination. Something about immortal person time that I will get back to in a little bit. And then we have in that period pregnancy losses. We have the malformations happening, and we can have long-term effects for exposures in the first trimester that might have implications, say, in placentation that later on affect preeclampsia, for example. And then we can say later in pregnancy, we also have some challenges of, for example, the third trimester being shorter when you have prematurity or when you have things associated with it like preeclampsia. So if we focus on vaccinations in the third trimester, those with preterm deliveries will have shorter opportunities for exposure. So each phase might have different specific methodological challenges. Let's focus on the early pregnancy type of vaccinations for this presentation. And when we think about that, we can think about selection because we often enroll or vaccinate after the eligibility, which is in this case being pregnant, therefore conception. And there can be some left truncation. So I have a question for you. So pay attention and think about it. If we go back to consider the distribution of miscarriages, and I ask you, what would be the relative risk of spontaneous abortions if the exposed subjects in your study are enrolled during the first trimester and say them on average, say around 10 weeks, and then you have to pick a reference group. If you have a reference that enroll later in pregnancy, and you'll say like, why would I do that? Well, imagine that you have a registry and now you have the exposed, and now you ask them to refer to friends or family members to participate in the study. For them to know that they are pregnant, the friends and family members may be obviously pregnant and may enroll a little bit later. So there are situations when you can have enrollment later for the reference and represented in green in the graph. Or what if the reference group starts follow-up enrollment at conception? So what will be the results, right? So going back to the vaccine, what if I tell you that among participants in a pregnancy registry receiving COVID-19 vaccine during pregnancy, 13% resulted in spontaneous abortion, relative to about 15% in the general population? How would you relate that to the question that I was posing? If the vaccination is around 10 weeks in red, and in the general population, we start counting from conception or from LMP plus 5 weeks to say that they are 15%. Therefore, in that comparison, unintentionally, we have a shorter opportunity for vaccination during pregnancy in those that have shorter pregnancies. Or, in other words, there is a shorter opportunity for having spontaneous abortion from vaccination to the end of this risk period, 20 or 24 weeks, than when we count from conception. And a related thing is that the problem is that the time from conception to vaccination during pregnancy is immortal for having a spontaneous abortion, because if you have it, then you are not pregnant anymore. So why would we do that, right? How can we fall into this comparison? Well, first CDC report with in collaboration, I know, with the FDA, a great idea to have the V-Safe, including also pregnancies. So very quickly they were able to identify and report that among 3,958 participants in V-Safe that enrolled when they were pregnant, 827 had a completed pregnancy, of which 13.9% resulted in a pregnancy loss, and the rest in a live birth. And they clarify that mostly among participants with vaccination in the third trimester. So what is happening with this report? First is restricted to completed pregnancies, and when pregnancies are shorter, is more likely for us to include in our follow-up cohorts because they are completed earlier. So that will be overestimate the risk of miscarriages. But then they included vaccinations after 20 weeks, which are not at risk of miscarriage. So that will be underestimating the risk of miscarriage. And then there is a shorter opportunity for vaccination in pregnancies with the abortion. So that will be underestimating the risk of miscarriage. So to their credit, CDC fixed this report before publication, corrected it for the final publication. And in that publication, they reported that specifically among those that received the vaccine preconception and prior to 20 weeks, the age, gestational age, standardized cumulative risk from 6 to 19 weeks of gestation was actually close to 13% as well. So sometimes, we have biases up and down, and they get up to the same number. So CDC corrected it, and just to be clear, reports from CDC and then other reports really were very reassuring, indicating no obvious safety signal for the COVID-19 vaccines in pregnancy. And in this graph, you have in red and blue population reports on the cumulative incidence of spontaneous abortions. And in the middle, you have the estimations from V-Safe and one estimation that we did from another registry that we conducted online that are really similar and within the expected limits. So I wanted to clarify that I'm using it as an example, but it was not a positive finding. So lesson learned: that the risk of spontaneous abortions in pregnancies vaccinated in the first 20 weeks is not comparable with the expected spontaneous abortion risk in the general population or in those not vaccinated between conception and 20 weeks. So my recommendation is, let's not do that. And it's so easy to fall in doing that. And why did I mention immortal time bias? Because to be vaccinated during pregnancy needs to survive without this outcome until vaccination. And the time between conception and vaccination is what we call immortal to the outcome of interest. If there is no outcome, no miscarriage, then you can get vaccinated before that time or after. But if you have the outcome, you can only get vaccinated while pregnant, so before that time. So if you like ducks, I'm putting there the duck for you. The outcome is affecting your classification of vaccination during that period. Same thing will happen at the end of pregnancy when you have shorter trimesters. There is kind of like a reverse influence of the outcome on your exposure. So when we define exposure as at any time in a period, that exposure definition is affected by survival, and fetal losses will be therefore, as a result, inversely associated with the vaccine or any exposure of interest even after the null. So I'm going to propose that if we use the target trial to think about our designs, it can help avoid us falling into this trap that is not totally intuitive for human brains and for all of us. So there are two key components when we emulate a target trial. One is the randomized assignment. So we need to do emulations thinking about potential confounding and who gets vaccinated, who doesn't. And if there can be differences, you need to adjust for them. But then there is another component that is the correct specification of time zero. And time zero must be synchronized with the determination of eligibility and with the assignment of treatments. And in epidemiology, we focus so much on confounding and often blame any differences with trials on the confounding and the lack of exchangeability. But sometimes we fall into the incorrect specification of time zero, and that can actually explain the differences between our results and the trials. So time zero in a target trial, in a randomized trial for each participant, is a time when three things happen. The eligibility criteria are met, in this case, conception or being pregnant. The treatment strategies are assigned, vaccination or not, and the outcome starts to be counted. So time zero, in this case, for spontaneous abortion. So the same applies to observational emulations. That is, the time zero for the emulation of the target trial must be synchronized with the determination of eligibility, conception, and the assignment of treatment strategies, in this case, the vaccine. Now, the challenge when we emulate the trial in observational data is that the treatment group vaccination is not known at the time of conception. We will only know whether somebody is vaccinated during pregnancy or not when we observe the vaccine, which is after time zero. And that's what can get us into trouble. If we have a misalignment of eligibility criteria and treatment assignment, that leads to selection bias and immortal time bias. And for that general concept, I will refer you to this publication in Journal of Clinical Epidemiology about this particular misalignment and how the different biases can be introduced. For the example we are discussing, let's think about how we can deal with the situation. We can define for the vaccine group that pregnant, meaning meeting the eligibility criteria, and that are going to receive a vaccine in the 90 days after the time zero. And therefore, we can define time zero as the first eligible time at conception or at LMP plus 5 weeks so that we can identify miscarriages. So LMP plus 5 weeks is our time zero for the vaccination group. But we are going to observe the vaccine later, so that initial time between the vaccination and between conception and vaccination is immortal time. And in the non-vaccine group, we also start from that time of conception or LMP plus 5. So aligned timings, but we had this problem of, to get the vaccine, they didn't have an abortion during the first X number of weeks. So that is not going to work because there is this misalignment between the eligibility criteria and the treatment initiation, and that leads to a selection of those that survive until vaccination and introduces immortal time bias. So what else can we do? Okay, to avoid immortal time bias, let's move the initiation of time zero to the time of vaccination for the vaccinated, and we leave the follow-up for the unvaccinated from conception. But then that doesn't work because the vaccinated will have fewer weeks to accumulate miscarriages, and the conception group, the non-vaccinated group, is starting from conception with more time and a peak of miscarriages. So to avoid that immortal time bias, we cannot really start at different gestational ages. That would be misalign the gestational age and the time of follow-up. And you can think, okay, we can do models that allow us to count person time, and we can deal with that. Well, these rate or hazard models can accumulate these different times of follow-up, but in this situation, they are not going to be comparable follow-ups because of the change of weekly rates of abortions. And if we use things like Cox, that will not allow us to estimate risk. We will have only hazard ratios. So the recommendation is, how can we align time zero follow-up for expose and references? Can we start both at the same time? And to do that, first, I need you to tell me which questions you prefer. I'm going to cover two of them. And the first one is, if your question of interest is, does vaccine X of interest during the first 90 days of pregnancy increase the risk of spontaneous abortions compared to no vaccination during this grace period? Then we have a whole grace period for the participants to get vaccinated. If that's what you are saying, is you are aligning eligibility and assignment at conception. Okay, that's fine. The thing is that to emulate a trial that assigns at conception vaccination during the first 90 days, time zero is conception, or 5 days later. Now, in observational data, treatment assignment is not known until you see the vaccination, or 90 days afterwards if there is no vaccination. So the subjects could be then cloned and contribute to both strategies until their treatment is evident, at which point they can be censored from the other strategy. And then we have to apply weights to adjust for informative censoring. And because we need to consider that the individuals are cloned, and therefore we need to account for that in the variance and using a robust variance estimation. And that's where this cloning and weighting method comes from. And it is really not that complicated to think about it. So let me walk through it with a graph. Imagine that this graph is representing like just 6 subjects with vaccinations indicated by this string, and pregnancy loss is indicated by the stars, and I'm going to use blue dots to indicate censoring. So if that's the real data, the problem is that you know in which group they are when they either get the vaccine or when you get to LMP plus 90 days and they didn't get a vaccine. So what we are going to do with this original data is, first, we are going to literally clone it. We have double our subjects now, which of course is not fair. We have to account for the variance to do that. But then in each clone is going to be assigned to the vaccinated group and to the not vaccinated group. And then for each clone, we are going to follow each subject and censor the subject when the subject violates that group. So, for example, subject 5 got in the vaccination group, got to the 90 days without the vaccination. Therefore, that person doesn't belong there. We censor. While in the right, you have the clones assigned to strategy 2, no vaccination. So every time there is a vaccination, we clone them. And the initial time is going to contribute until the cloning or the assignment is going to contribute to both clones. And then we conduct analysis in this clone population, use robust variance to kind of account for the fact that we duplicated our sample size. And then we can account for the potential informative censoring if the characteristics in one group and the other are different. So that's one way of dealing with the situation with this cloning and weighting and censoring. An alternative question will correspond to a different trial. And that is the following question. Does vaccine X at the first prenatal visit in the first 20 weeks of pregnancy increase the risk of spontaneous abortion compared to no vaccination? So in this case, we are aligning the assignment of the treatment and the beginning of follow-up by putting all of them at a given gestational age versus at conception, but they are still aligned. And this solution also gets us to an homogeneous distribution of gestational age at time 0 for the exposed and the reference group. The tricky thing is that now we have multiple potential time of vaccination. So what we can do to account for that is what we call a sequential trial. We will emulate a new target trial each week of follow-up. So time 0 will be different in each trial, and then we'll include in the emulation of each trial all individuals who are eligible, therefore not previously vaccinated and still pregnant at that time, at that corresponding time 0 for each trial. Then we'll combine all those target trials to have the most precise estimation. And then again, we need to consider that some individuals are contributing to more than one trial, so we'll use a robust variance. But in these methods, by using the full information, we're using as much information as possible, even when we have to then adjust the variance. There may be other approaches that will get you to alignment of gestational age and might not use all the individuals, all the information in the data. So how do we think about this sequential emulation graphically? So if we start these trials in the first LMP plus 4 weeks, at that time, those that are eligible, meaning still pregnant and not vaccinated before, will be assigned to vaccination versus not vaccination. Those that are not vaccinated will be eligible in the second week to have vaccine or not vaccine. Those not vaccinated that week will be eligible, and so on and so forth until 19 weeks of trial. Now, 2 slides about pregnancy registries, because we do so many databases that sometimes we forget that there's also ad hoc collection of data. In the pregnancy registries, the time until vaccination is immortal, because we cannot have spontaneous abortion and still be pregnant at vaccination. But also, if your inclusion in the pregnancy registry is currently pregnant, so you enroll because there are pregnancies and then you ask about the vaccine in the past months, then if you enroll during pregnancy, then the time between conception and enrollment is also immortal to a spontaneous abortion. So you have this kind of double immortal time coming into the pregnancy registries that you have to be careful with. And the thing is that when you are doing this prospective enrollment of pregnancies, you first can miss abortions that happen right after the vaccine if you do not enroll those that had already the miscarriage. But the problem is that if you were to include these miscarriages, you might have an overestimation if there is a self-selection of those with the spontaneous abortion. If you exclude them, you can be underestimating them. So something to consider if you are doing pregnancy registries. This double immortal time, and then the problems with the retrospective inclusion of those that already had the outcome. It's kind of like a no-winning situation. So 2 slides about the specific example we use for safety. Our question of interest was, does vaccine X at the first visit in early pregnancy increase the risk of spontaneous abortion compared to non-vaccination? And we emulated this study trial using a large healthcare utilization database. So just as an example of how the protocol will look like if you do something like that, we had our eligibility criteria for the hypothetical trial and the emulation. So the enrollment period, in which gestational age we will consider in a real trial any age restriction. In our database, nested hypothetical target trial, we hypothesized that we will allow enrollment if the persons were in the insurance for 6 months at least before the initiation of the trial, because we are going to use all the baseline covariates during the analysis, that they had no recorded infection and no vaccine. So the same will be for the emulation, and we will use the information in those 6 months before enrollment to ascertain eligibility criteria. Then the treatment strategies were first dose of vaccine at enrollment and then second at initiated versus not vaccinated before at least before 20 weeks, and they could be vaccinated. And we ascertain the vaccinations, including the brand names using the pharmacy dispensation. So they are in your emulation. You can argue whether you can be missing vaccinations outside the system and introducing misclassification. And in the target trial, we will of course randomly assign the vaccination. We do not have that in the emulation, so we will discuss what are we going to do to try to make the groups more comparable by adjusting or matching IPW, propensity scores, you name it. Then we had the follow-up. In the target trial, it would start at vaccination assignment and at spontaneous abortion or 20 weeks after LMP or losses to follow-up. In the case of databases, these losses to follow-up may be disenrollment from the insurance, for example. In the emulation, we'll also start at first vaccine dispensation or procedure and match, as I explained, for the sequential trial. And in terms of follow-up, the problems with the databases, for example, is that to assign pregnancy status, we need to have to identify N of a pregnancy outcome, either delivery or spontaneous abortion. So when emulating pregnancy cohorts in databases, we knowingly or not, maybe not explicitly, but we are doing a complete case approach in the sense that we only are following pregnancies that we identified. So that might have implications with potential selections that we are introducing. For the outcome, we'll try to identify spontaneous abortion. In your emulation, you can discuss whether you think you have good algorithms to identify them. And then we emulated on the observational analog to the per protocol. So with this, I want to give an example of how a table can look like and how you can try to emulate each thing. And if you identify things that you have to do slightly different with your observational data, you can discuss, well, I don't have random assignment, but I'm doing this and that. I have to restrict to those with identified deliveries. Therefore, I might be introducing this selection bias and so forth. And then the analysis we did the same we will do with a target trial with survivor curves. So in conclusion, we learned with the presentation today, I think we share the knowledge that the defining exposures during a period in pregnancy, anytime during the first trimester, anytime during the third trimester, can introduce immortal time bias. That applies to losses, applies to preterm deliveries if you are focusing to the end, in the end of pregnancy type of periods. So the solution that I was proposing today is conceptualizing your design first as a hypothetical target trial will force us to define the causal question and specify the population, specify time zero and the outcomes. And by doing that, we might avoid falling into some of these biases. And to align gestational age at time zero, we propose today using cloning or sequential trial emulations. You can do other things, adjust for them, standardize or match on them. The intention is to have the same gestational age at initiation for both your exposed and your reference. And talking about reference, I'm leaving you with a few references at the end of the presentation, but that's all I had. So now we have time for questions and discussion. Let me stop sharing.
Right. Thank you, Sonia. That was great. So I see we have some questions in the chat. So Zong Yuan, you had a couple questions you wanted to ask?
Yeah, thanks. Can you hear me okay?
Yeah.
Yeah, okay. So I think in my second question, you probably addressed it using cloning method or sequential trial emulation, I think. So let me repeat what the first question, and I can quickly talk about the second question. My first question is that while you're matching patients vaccinated versus non-vaccinated, you control the medical condition using medical records. But vaccination is one thing, it's a little bit unique. Some people just don't believe vaccination, therefore they don't take it. And then it could be also even driven by other situation, exposure status, whether you more casually goes out during the pandemic stage, especially COVID, people just don't really care, still go out, and therefore their contact the people potentially infected could be very different from people vaccinated because they're more conscientious about the potential infection state, even you vaccinated. So would that be still considered as a potential remaining source of confounding when they're leading to hospitalization because they're not careful about the infection? Therefore, it's not saying if they have used a similar careful behavior contacting people, their hospitalization due to pick up disease may be similar to vaccinated people just because they're different. That source not control. Could that be source of confounding from your perspective?
Yeah, thank you very much for the question, because I was proposing the target trial to avoid this selection bias or immortal time bias. But I do not want anybody to think that I'm saying that with the target trial we can forget about confounding. The confounding is there, and if you have these sources of confounding, they will remain with your beautiful target trial, and you still have to deal with them. And I agree with you that the vaccinated and the not vaccinated might be different for reasons that can be unmeasured to us, so we cannot control, and that can be associated with the risk or the diagnosis or coding of the outcome. And if that's the case, and we cannot control for that, we are going to have residual confounding. And you can have the most beautiful target trial and call it a target trial in the title and still have that type of confounding. So that risk of observational studies will remain with target trial. And so I know many of you and others have done observational studies on vaccine using vaccines using observational data, and the lack of comparability is always a concern. There are approaches that might not be perfect, but depending on the vaccine that you can think about, for example, to include those that are not totally hesitant around vaccines, you might want to restrict to those that had at least one flu vaccine in the last year. So you can try to look for more comparable populations. Whether that's enough as to have no residual confounding, I think it's going to depend a little bit on the outcome and on the specific vaccine, but certainly it's a source of, like, we have to think about it when using observational data. So thank you for the question. Yeah, you are totally right.
Yeah. My second question, if you can elaborate a little bit more, just quick, because other people asked a question as well. The second one is the immortal time bias. You're absolutely right. When you get at the time being vaccinated, in order to be vaccinated, the pregnant group, they have to be survived to that time. But in the meantime, you can also select the patient who not vaccinated, also have a similar pregnant time already, but not having spontaneous report. And from that case, you also eliminated both immortal time bias from both groups. But the only question remains is that because you cannot use propensity at that stage, so you are creating a pool of patients for non-vaccinated patients. They all have similar survival time for each individual at the time. But that pool of patients, when you use the propensity matching stuff, do you think adequately addressing the potential immortal time bias? I know you talk about cloning and also sequential trials. That seems like sequential trial emulation very similar to that approach. Just want to hear, make sure I'm understanding that correctly.
Yes. So when we have not everybody vaccinated at LNP plus 5 weeks, and they are vaccinated later on during those 20 weeks, there are two things that happen. That the later towards those 20 weeks they are vaccinated, the shorter time they have to have a miscarriage before 20 weeks. So there is a selection, if you wish, of those without abortion, both for the vaccinated and, if we were to match, for the not vaccinated. So that in itself has implications for the interpretation of the findings. So if you had one study, observational or not, where everybody is vaccinated in week 18, the results might be different. The risk will be for sure different, but even the relative risk might be different from a study or from a population where the vaccinations are occurring at 10 weeks or before. So I think we have to pay attention to that selection over time in general for the interpretation of the findings. So that's one thing, that the kind of selection over time. What we are trying to avoid is that time without the abortion is the same for vaccinated and not vaccinated, so that we do not start the follow-up for the vaccinated before identifying the vaccination, because that time is immortal. So when we do not count that time as vaccinated, the problem was that we had these different gestational ages and we had to align them, right? So yes, with any of the methods I mentioned, we will not have immortal time bias problem. We'll be aligning things. But as you say, we still need to think about the timing of vaccination. And if that timing is different in different populations, results for the risks, for sure they will be different. For the relative risk or risk differences could potentially be different if the vaccines had different effects early or late in that first 20 weeks. So timing is still something that we will have to consider with any of the methods that we discuss. I see George Ripskak has a hand up, but
yeah, so I see George, and then we also have one in the question in the chat. But George, if you want to go first.
Sure. Hi, Sonia. First of all, thank you for such a clear talk illustrating the bias and the solution. So that was wonderful. My question is about target trial emulation and vaccine studies, not specifically pregnancy. Ostropolitz published a paper that showed in the first, if you do a cohort study and the vaccine side effects and the disease effects are similar, that in the first week, you should see a false effectiveness because people aren't going to show up because they thought it was the vaccine and not the other thing. And she did chart reviews and stuff like that. So what would be the target trial emulation solution? Is it just to start counting after the week, or is there some other way to do that?
Great question, because you are totally right. Because of, we can call it confounding, the first week of the vaccine, we know that there should not be efficacy or differences, but because we do not vaccinate those that are about to die, we know that we have this important bias of healthy vaccination bias, right? That after vaccination, any vaccination, mortality is usually lower, and COVID infection is probably lower too for COVID vaccines because you will not vaccinate somebody that is actively clearly infected, right? So the studies for COVID vaccines had to deal with that, and actually the first 2 weeks for COVID vaccines where you do not expect effectiveness, if you see a separation of the curves, I don't think we just can like not present that and delete that because we don't like it, because it doesn't make sense. But we can use that as a sentinel indication for residual confounding. So if we see the separation of the curves from day one, we still have residual confounding, and we have to go back to our design and try to do better. For example, we could require like no hospital visit or infection diagnosis or checkup for fever in the week before vaccination, or other kind of clever ways that you probably can think of for specific vaccines that can really clean that healthy user. And then if we go back to the blackboard or whiteboard and try to do better with confounding, and then with better inclusion criteria, we get to overlapping curves, I think that will give us a peace of mind. But that the temptation that you said that we'll all have, like, okay, let's present it only after 14 weeks, is kind of hiding and the evidence of residual confounding, I think.
Thank you. The thing that Ostropolitz argued was that the first week is a known temporary thing, though, because this bias is not from before the vaccination, but after the vaccination. It's something where you know that you don't show up to the doctor because you know you were vaccinated. Therefore, after a week should go away. And that she argues that in fact that's still that it's not a good negative control. That the first week is not a good negative control because
Okay.
even if they were matched on the way in, they will differ in the first week no matter what you do.
I see.
And then they should align again. And maybe the second week would be a good negative control, but not the first week.
Okay. Yeah, that makes sense. So I think that a point that I want to highlight, and this is not like a Nobel Prize for me, is that subject matter knowledge and knowing the data, knowing the population, knowing the behavior is totally essential to interpret what is going on.
Well, thank you.
Because yeah, that makes total sense, right? And yeah, and probably it might affect some softer outcomes more than others, right? Like let's
She
say,
found
like
actually that mild COVID went away, severe COVID was equal. In other words, the mild one, they didn't show up because it was probably the vaccination. When it became severe and they couldn't breathe, they knew it wasn't the vaccine anymore. So that stayed about the same between the two groups.
Makes
Anyway,
sense.
thank you
Yeah,
very
yeah.
much.
Yeah, yeah. Makes sense. Yes. Yeah. And I think, and that's not part of this talk, but I think the interpretation of our findings like usually have alternative explanations or potential and saying like this is the finding and this is how I interpret and why. And sometimes we have evidence to support, right, the interpretation, and sometimes there might not be evidence, but it's still what you said like makes complete sense, of course. Yeah, thank you.
All right, so we have two questions in the chat. I guess we can try to get through both of them. So the first one is from Nick Andrews. Nick, did you want to ask your question?
Oh, thank you. Yes, nice talk, Sonia. Thank you for that. Yeah, I've done a lot of thinking about target trials, thinking about the RSV vaccine, really. Yeah, one of the issues was around if they go on to if they're recruited as the control, but they go on to get the vaccine, um, dealing with them. I think I've seen studies sort of potentially censoring at that time point.
Yeah.
If they should go on to one, I was just wondering if that's something you agreed with to deal with
Yeah.
that. And the second
Yes.
one, which I've had more trouble about, is actually the issue of if there's other vaccines that they go on to get and how you deal with that, if they're ones which might be of interest in terms of the same adverse events, for example. So I
Right.
had a bit more trouble on thinking what to do.
Yeah. So for the first question, it's a key question. There, I know there is a lot of methodological discussion of meaning like if you have somebody in your match or in your not vaccinated group, and then the person gets the vaccine, you're right. Like what I have seen is that like you censor at that time. The discussion is if you are like, for example, matching very finally, but in say for neighborhood, and so that you have the vaccinated and just a few non-vaccinated. One question that I've seen the discussions is if the not vaccinated get the vaccine and you censor that person, do you also censor everybody else in that matching thing? So that's like a method discussion that has different implications in the timing when very few were getting the vaccine. You had plenty of not vaccinated. But as vaccines started coming very quickly, many studies that had the vaccinated, many of the unvaccinated were getting the vaccine. So then it's really relevant. Whatever you do might really affect the results. And it became like a methodological question. I don't know all the mathematical details behind each of them, but initially, yes, we were censoring. Whether there is a better way, I think is still up for discussion, or like can be so statistically, methodologically detailed that it's beyond my area of expertise, but it is a key question. I know it's a key question. I can say that. And regarding the other, like the multiple vaccines, I know that that's a hot topic right now when there are more and more vaccines during pregnancy, and whether vaccinating at the same time or vaccinating like only with one vaccine can get you different results, particularly if you have the same adverse event of interest for both vaccines, right? So I know that there's an area of exploration and to identify how to evaluate that. From the target trial perspective, my initial thoughts about it is that perhaps we need to define the full strategy so that the solution, the strategies to compare are not vaccination, say, with flu versus vaccination with flu and COVID at the same time, because those two things are not going to have the same benefits in theory, right? Because with one, you're only get one vaccine. So I think the question is vaccination at the same time versus vaccination with one and then vaccination with the other. And it is more kind of the cloning situation because the strategy is defined at the beginning, and then you have the one or two or more vaccines. But I think my point when we start comparing these strategies is that if the goal is to vaccinate about all the things, then we cannot compare one versus the two because they don't have the same benefits. So how can we put them in the same contrast?
Yeah, no, that makes. I mean, I had thought about if the idea is to look at more than one vaccine, to the idea of looking at the point at which they've had two or three of the vaccines, and sort of doing the target trial from sort of that point onwards. Yeah, I think it's kind of what you're saying. Yeah, I agree. The censoring, I think, is what the approach I'm planning to use. And if there's multiple, given that you censor both the vaccinated and unvaccinated, if they're given if multiple non-vaccines have been recruited to that same vaccinated, you probably end up, if you do a conditional analysis, they'd all drop out anyway. So I'm just thinking stats wise, that's probably what would happen. Great, thank you. And thank you for your comment about the hospital. If they're in hospital, you might not want to recruit them because they're in because there might be that might be healthy vaccinia things. I've thought of exactly the same sort of idea. So I'm glad to hear you commenting on that as well.
Yeah,
Thank you.
yeah. I've seen papers finding that like mortality reductions, and in pregnancy I had that also. Sometimes I think there may be that if early in pregnancy you have cramps because of a miscarriage going to happen, you might go to get checkup and you might get the vaccination for flu, let's say, just because you went to. So there are all like patterns
Yeah,
of care
educated, yeah.
subtleties that are interesting.